All right, we're still having people join, but I'll go ahead and get us started since we are at 6 p.m. Mountain Time. So my name is Joshua Knotts. I am the Vice President of Strategy and Experience at Joyce University of Nursing and Health Sciences. I'd like to welcome our participants to today's Tuesday Talk lecture on team-based approaches to sports injury management. A little housekeeping. Before we get started, the lecture will last approximately 40 minutes. And then we'll open it up to a Q&A at the end. You may type your questions throughout the presentation in the Q&A button. You should see that in the bottom of your screen just to the right. And our moderators will support us in facilitating the discussion. For those who don't know, Joyce University was founded in 1979. We are an NWCCU accredited university, but we're primarily known as the largest pre-licensure nursing university in Utah, offering accredited pre-licensure nursing programs in Utah, but also in Colorado and soon to be Arizona and Idaho. We also offer post-licensure nursing degrees available throughout the United States, as well as health sciences degrees in occupational therapy assistant and respiratory care. Joyce University's Tuesday Talks are a way for us to invite our faculty, students, and healthcare professionals throughout the United States to engage in discussion that improves patient care. So today's Tuesday Talk was inspired by a recent on-the-field incident where Buffalo Bills safety Damar Hamlin collapsed after making a tackle, suffering a cardiac arrest. The quick reaction from first responders and the team-based approach to Mr. Hamlin's care are largely credited for his remarkable recovery. In this lecture on team-based approaches to sports injury management, Dr. Jordan Utley, Corporate Education Director at Pima Medical Institute, will highlight contemporary sports injuries, uncommon injuries like the one Mr. Hamlin suffered, and common acute chronic injuries experienced by active populations. In addition, a special focused on recognition treatment of post-concussion symptoms will be included alongside discussion of contemporary interprofessional team-based care. Organizing today's Tuesday Talk series and joining us in today's webinar is Joyce University's Dean of Nursing, Dr. Janet Houston, as well as long as support from our admissions team in Taylor Nakatani and our great marketing and student advising teams as well. So we're here to support you if you have any questions. Let me start by sharing a little bit about our speaker, Dr. Jordan Utley. Dr. Utley has over 2 decades of experience in higher education administration in roles of program director, department chair, and dean of health sciences. She has nearly 30 years of clinical experience as a certified athletic trainer, working with athletes from high school to professional sports, including the men's and women's U.S. soccer teams. She is an international scholar, publishing and presenting on her work in interprofessional education. Dr. Utley's research includes utility of biomarkers that pass the blood-brain barriers as diagnostics tool for sports-related concussion. In addition, her research studies effectiveness of interprofessional education across systems and education to create behavioral change in practicing clinicians. Dr. Utley believes in educating graduates to be change agents of healthcare, to lead interprofessional, patient-centered care teams that are population-focused, cost-effective, and foster personal and professional well-being. Thank you for joining us, Dr. Utley, and with that, I will hand it off to you.
Thank you for that introduction, Josh, and I'll just get my slides up here in a second. Okay, it should all be coming together. You should see me shortly in the lower half. Okay, again, thank you for that introduction, and all systems appear to be go. So thanks for joining me this evening for team-based approaches to sport injury management. When I was approached to give this talk this evening and asked to cover the contemporary event of the injury on the NFL field a few weeks ago now, I saw it as an opportunity to educate other healthcare providers on the role of an athletic trainer in that setting and beyond. So I took the chance, and I appreciate getting the opportunity to do so this evening. So the elements of the talk for tonight, let me start my stopwatch so I stay on track, are healthcare teams, just broadly general, and then looking at the sports medicine healthcare team. And then uncommon injuries like Commotio Cordis, we'll cover that, as well as common injuries, acute and chronic versions of those injuries. So I'll cover 4 of those this evening that are really common in those individuals who are engaged in sport or even recreational sport. And then a special spotlight feature on post-concussion symptoms. That has made a contemporary change in and of itself, going from syndrome to symptoms. So I wanted to cover that. I saw this as an opportunity to do so. And then wrapping up the talk following that. So first, starting with healthcare teams. Teams come in different shapes and sizes, just like our colleagues at work and the teams that we work on in the academic sense. Healthcare teams also come in different shapes and sizes and roles based on settings. So I wanted to sort of open the talk this evening with taking a look at some different healthcare teams and why we team. So here's a quote from the World Health Organization. Collaborative practice happens when multiple health workers from different professional backgrounds work together with patients, families, and communities to deliver the highest quality of care across settings. So it really lays the groundwork for why we team. And when I talk about collaborative practice, I'm going to use the word teaming throughout the rest of this talk. I think the field of nursing aligns with the terminology of teaming and understands that practice. And we're really focused towards improving that patient care. So this cartoon, I use it in quite a few of my talks because I think it's instrumental in sharing the message of we need to speak across silos. So oftentimes, in hospitals, there's a floor dedicated to a specific element, or in a college or university setting, there's the School of Nursing, and there's the School of Sports Medicine, and there's the School of, well, when we set ourselves up that way, it's difficult to have that multidisciplinary or interdisciplinary communication. So this cartoon highlights that sort of experience as a patient, and many of you on the call tonight have been a patient, if not recently, and gone through this, where you check in, maybe it's the medical assistant that checks you in, and then you cascade forward to the PA or the NP, and the same questions are asked. And it's often, ruminating in your head as a patient of, did they even read my file, or did they talk to each other? So this cartoon really highlights the power of communication and how that patient feels as a result of that care provider next down the line already knowing the case. So it's important in our care of the patient. Improving healthcare, also communication is critical here. So I included this slide. It's aged a bit, but I will tell you that the current data is not out yet, advancing beyond the slide. So medical error was the 3rd leading cause of death in the United States at this time, behind heart disease and cancer. And a lot of that has been attributed to the lack of communication between teams providing that care, and mistakes, of course, medical errors, but communication being foundational in contributing rather to medical care or to medical error. There's an opportunity here for highly functioning healthcare teams to make an impact. So it folds into this talk tonight and thinking about, okay, well, why do I even care about teaming? Why does it matter? Well, it matters for patient care and the quality of care we're able to provide. So this quote comes from the work of Encycle, which is focused on, it's one of the IPE organizations, and it focuses on that clinical aspect of education. In those students that are going through Joyce right now in the nursing programs, or OT or RT, and really, when they go out to their clinical site, what kind of teaming are they seeing? What are they being exposed to? So this quote says, hey, the next generation of our healthcare workforce needs the skills to be able to lead change in our nation's healthcare organizations, both large and small. Our graduates not only need to have that capacity to engage with their professional identity, but they need to have that interprofessional change agent mantra to be like, hey, this is an opportunity, let's lead this change in this area. Joyce also has an opportunity not only at that entry level, but at that postgraduate, post-entry level echelon to have those graduates be those change agents. If not at the entry level, then at the graduate level. So be thinking about that as you develop the curriculum. The impact of teaming, I think, is best illustrated by the triple aim, the Institute of Healthcare Improvement, and how it has advanced across really 3 decades. 3 different 7-year cycles you see here. So the triple aim emerged in 2007 with 3 main components. So improve patient experience, so that patient satisfaction piece, better outcomes, which really hangs its hat on population health, and then lower cost of care. So the United States at this time had the highest, well, still does, the highest healthcare costs, yet failed to rank in the top 10 of patient outcomes. So when we think about that, advancing 7 years forward to 2014 in the quadruple aim for healthcare, adding clinician well-being, and the timeliness of adding this in 2014 was neatly tied with clinician burnout. So in this situation, increased patient loads, lack of supports, really pushing folks to their limits, and then healthcare providers backing out of the profession as a result. So one of the key studies that came out of this era in the 2014, 2016 timeframe is co-officing, which I thought was really unique and I wanted to mention tonight. So as people hospitals, organizations were attempting to combat burnout, co-officing was tested or assessed. And what does this mean? So this means the physician on that floor or attached to that unit is officing with the nurses, not just the charge nurse, beyond that, the nursing team also officing with any support staff that's on that floor, whether it be nurse assist or nursing assistants or LVNs, whatever it might be. But that whole team is maybe it's an x-ray tech too, officing together and collaborating together, scooting their chair back and looking down the aisle and making a comment to a colleague. And that co-officing structure did impact burnout, lowered that burnout level, and increased the sustaining element of having that person maintain employment at that hospital. So there are some unique studies out there that really show the power of collaboration and teaming and how it can keep our clinicians happy. When we keep our clinicians happy, we know patient care is impacted. And then advancing 7 years forward to the quintuple aim. This is adding a very timely piece here as well. In number 2 in 2007, better outcomes, population health. Number 5 here in 2021 is really dialing it in or sharpening the pencil, so to speak, on health equity. What does that access look like? And what is the quality of care someone is getting in a low SES environment versus a Mayo Clinic scenario? How does that look? How does it unfold? And is it equal? Is there equity there? So looking across this 21-year period, or this rather 3 7-year spans, seeing the advancement of the triple aim to the quintuple aim really shows you the impact of the healthcare team and leading to better health as a population and improved healthcare economy. So I think that also shows the impact of teaming. So here's a depiction of what a potential hospital team might look like. So in the center of the screen, you have a green sort of continuum, a bar that shows from patient intake to discharge, sort of the life cycle of that patient. And then the solid lines are practitioners, healthcare providers who have direct patient care roles for this particular patient. So a doctor, respiratory therapist, OT, SLP, and so on. And then the communication dotted line, sort of that ancillary support and communication, that's depicted by the dotted line. So it isn't a direct to the patient, but it is, collaborating behind the scenes. So for instance, the respiratory therapist sees the patient and says, hey, this is something the OT needs to know. So that collateral communication occurs. So this is an example, a depiction of what a collaborative team might look like. So that same collaborative team looks a little different when you apply it to the sport healthcare team on the sideline. So that's what this depicts as we will roll into talking about Commotio Cordis in a bit. But in this picture, so imagine it just like the infographic that you just saw with the shapes and the dotted lines and the solid lines. So in this picture, you have 3 EMTs, paramedics in the blue polos. Then you've got 2 athletic trainers in the red polos. And you have a team physician in the blue polo to the far right, and then an unbiased physician in the Oxford, the white Oxford, sort of at the back right. And then we have a trailing physician on the left, and he's in charge of airways. So when an emergency happens, there is a finely tuned emergency action plan that these folks utilize to communicate with each other, to work in rhythm, to make sure that that athlete is transported as quick as possible, safely and as quickly as possible. So that's what this picture or this depiction is illustrating here. Now, once that athlete is transported, the emergency department, another set, sort of like Team B, then picks up. And this is also a critical facet or critical time in the exchange of the patient for communication. So oftentimes in working in the education environment, we study through interprofessional education simulations. We use simulations and we study the effectiveness of those. And when building a simulation between licensed practical nurses, LPNs, and paramedics who typically come to where the LPN is working in Texas and pick up that patient from the nursing home, that communication was suffering. So creating a simulation around that to make sure that patient handoff was quick, succinct, as well as fruitful with information needed by both teams, team one responding to team two. So that was a critical piece with simulation in my past life that we were able to iron out. And it was, the hangup was communication. So keeping that in mind about why these EAPs exist and why this collateral dotted line piece, why it's so important in the function of a collaborative team. Here's another example of how this might work. Now, please don't get hung up on the small text in the boxes. It is the idea is a flow chart of how to respond to sudden cardiac death. So I don't want you to focus necessarily so much there, but I'd like you to focus on the right side of the slide and think about that healthcare team on the sideline, working through that emergency action plan and considering the roles. So here I have a set of 4 different teams that are on the sidelines to respond to this particular injury. So the immediate care team is Team A, and they're the ones that are running out there that you guys see on the fields when you're watching the football games that run out, and that's Team A. And Team A is responsible for assessing primary and secondary assessment and deciding what do we have, what do we need. Now in the NFL scenario, all healthcare providers are connected with ear wires so they can hear, everybody can hear each other. And they're roughly on average anywhere from 30 to 35 healthcare providers on the sideline for any game. So Team A is that core of folks that run it onto the field and assess the scene. Like, what do we have? What are we dealing with? And then Team B, they're in charge of emergency equipment retrieval. So these folks listen and they wait and they hear what they need to bring out onto the field. And then you'll see a second wave coming out. And the activation of EMS, when that decision is made, that's Team C. Now, this process looks different based on setting. So if you have an ambulance already on site, I'm thinking about Texas high school football, there's always an ambulance in the corner of the field. Then it's a matter of hand signals to call that ambulance to the center of the field. In some cases, the ambulance is not there. So the EMS needs to be activated or summoned to that location. So that's Team C's job. Well, you've got Team A still providing that care, beginning CPR, whatever it might be. Team C is activating EMS and getting that emergency transport to the location. Then finally, Team D, this is the final team, and this is that team. I'm especially thinking about college campuses here that may not have the ambulance at the site or at the field. And these individuals actually go out to doorways, go out to the end of the block, go out to maybe pressure points or pain points where the ambulance might take a wrong turn. And they're there to guide the emergency vehicle to the stadium or to the gym as fast as possible. So that's the role of Team D in this scenario. So with that said, we'll take a look at our first injury, which is Commotio Cordis, as an uncommon injury, which is rather rare. So let's take a look at that one first. So I put the phonetics there because I've heard this pronounced so many different ways. So it's Commotio Cordis, and it means, it's Latin for commotion in the heart, which is very on the mark, right? This is sudden death, sudden cardiac death. And the analogies in the press, and one I hung my hat on, which I really like, was blowing a fuse in the heart, which I thought, gosh, that's, something a lot of people can think about and understand. So when you blow a fuse at home, you plug in the air fryer and something else at the same time, and it blows the fuse, everything goes off and it's dead. And then you have to go out to the fuse back and flip it back on. Fuse box, and flip it back on. Well, in the case of Commotio Cordis, that's essentially what happens. The fuse trips. And there are factors that are associated with that fuse tripping. So I wanted to go over those tonight too, because I think it's critical in the understanding, even if it's a lay understanding of how this occurs. So individual differences, number one is the heart's position in the chest. So the heart isn't in the same spot for everyone. And it can be forward tilting, it can be rear tilting, it can be closer to the chest wall, it can be further within the chest and not so close to the chest wall. Chest wall thickness is another individual difference that comes into play when you think about Commotio Cordis and it actually occurring. And the third piece, which I think is the most amazing related to this injury, is the timing, the rhythm of the heart, the EKG wave, the QRS complex, and the timing of that complex. So when the actual blow to the chest occurs, it has to occur between 10 and 30 milliseconds on the ascending T wave. And I'll show you a picture of what that looks like in a minute. But think about this now, the position of the heart in the chest, the thickness of the wall. And when you're thinking about professional athletes, they have pretty thick musculature, right? So you're thinking, wow, that wall had to be thick. Well, is it the position of the heart? Is it exactly where it hit and it wasn't that thick? It was over the rib cage? You know, you're thinking through all of these things. And then at that, it's not even a split second, it's a split millisecond, right? At that particular time point, that impact happening. When the T wave is ascending and then boom, the hit happens. And then additionally, there are sport factors to consider. So contact versus non-contact sports, velocity, and it's not going to be what you think. I'll tell you that now. And then velocity of the object, as well as hardness of the ball or puck. Now, when you're thinking about football, you'll see in a minute that, I mean, we're not worried about the object in that sport per se. So here is the, here's a pie chart that looks at the hardness or the object, the sport equipment actually causing the Commotio Cordis. So sport type, we're not necessarily doing a contact, no contact. When that injury occurred in the NFL recently, a little over a month ago, of course, all the critics come out for football, right? Myself included, even though I'm a part of a sports medicine team, I'm saying, hey, it's dangerous. But in this case, it's not the contact or the non-contact aspect of that sport. It is thinking about objects that are being used and the velocity of those objects that are being used. So in this case, baseball, 61% of the injuries, Commotio Cordis, were caused by being struck with a baseball. And then a softball, 16%, and then followed by a hockey puck. So those together, 89% of the injuries in this study were not even considering football, right? Because of the object itself. So we'll look at that next. Also related to incident is the age of the participant and the activity type. So is it competitive? Is it recreational? So this is a very informative clustered histogram. When you look at the age groups of 11 to 15 and 16 to 20, basically you can collapse those. So we got 11 to 20 as one group, and then we've got under 10 as the other group. Now the main difference here is the survivors are less, but then also competitive sports. We've got, less than half of the folks in under 10, and that makes sense. So it's a different group in the under 10 years old, equal to or under 10-year-old group per se. And then as you get older, 20 to 25 and greater than or equal to 26, you have to think about who's playing sport in this group that's being exposed to Commotio Cordis. And it's really post-college, right? When you get up to this age, and those in professional sport. And this came from a study of 224 cases in the National Registry. So it's a good description of recent cases, and it's 2010. When I say recent, it's a rare incident. So it's a large grouping of those incidences. This is the look at non-contact sport versus contact sport, and I've put them together for you. So the top two sports that experience Commotio Cordis are non-contact. So a lot of times, again, when football gets a bad rap, as far as this injury, this sudden death injury, it doesn't occur usually in football. It's number 4 of incidents in that sport. So baseball, you're looking at the hardness of the object, the speed and velocity at which that object is hurled towards its target. And that usually being a first baseman. So there's someone on that base that's trying to catch that ball that's moving at a super high velocity. The other scenario is a ball coming off the bat, and that pitcher and how close they are to that and the speed at which that ball is coming off that bat. So baseball being number 1, softball being number 2, and then hockey, thinking about the hardness of the puck and the speed and velocity at which that puck is put into motion. And then football being number 4. The football contact sport piece, being hit with a helmet or protective equipment that athlete wears is likely the blunt object. But here you see on this photo as well, a fist or an elbow is also. So it can be a body part that flies through a tackle or something like that in a pile, and it can be the projectile in this case. So mechanism of injury, I thought this was a good depiction for the audience to sort of understand Commotio Cordis. So the baseball strikes the chest, and then it sort of gives you the anatomical view on the far right. If that heart is in close proximity to that wall, you can see where it might make an impact. And this sometimes has been called a concussion of the heart, which it's not language that everyone uses. Commotio Cordis is the correct, but the lay term. And then also the bottom, which I promised to show you, was that sort of upstroke of the T wave, or that ascending T wave, and where that impact has to take place. So thinking about those individual differences, size of the chest wall, position of the heart, and then thinking about the exact point in the heart's rhythm where that has to occur. And then you see V-fib as a result in this case. So what do we do on the sideline when we have a Commotio Cordis event? The recognition is typically initial impact. So the athlete goes down, and athletic trainers are trained to watch the game, watch the play, and look at, be at the line of scrimmage and watch the contact of bodies. But, this injury occurred away from that. And so there are lots of folks, 30 plus, that are watching the play on the field. So you're watching that impact. You're watching people get up from tackles. We've got people in the sky that are watching, athletic trainers and medical professionals watching the field from above and indicating, calling down and saying, hey, potential concussion there. But in this case, the athlete rises, takes a few steps, stumbles, and then collapses again. This is pretty much how the majority of these injuries occur. Now, in one case, in doing the research for this talk tonight, was an anomaly in which a baseball pitcher, and there's a video of this online if you care to do the deep dive, gets hit in the chest he's pitched a ball, it hits him in the chest, and he goes down immediately. He gets up, gathers himself, throws the player out at first. And then as he's gathering to prepare his pitch, he collapses. So there is an individual difference too in the period of time following the impact to the body at which the person can sustain that V-fib rhythm. So that's also an individual difference in this injury that you're going to see, but eventually it's not sustainable. So that's why it says 10 to 20 seconds for that rise. Typically it's less than that, but in this case, the pitcher was able to execute and then begin to make another pitch. The treatment of this injury is really an EAP, it's prevention. So having that emergency action plan, that's what that stands for, ironed out and rehearsed. And in the NFL, it's rehearsed at least 1 hour before the game with all medical professionals who are working that event and the referees of how everything's going to go down, where equipment is, how to prepare for something like this to occur. And this happens at every game. So this is a well-rehearsed plan, and everyone knows what their role is. So like I highlighted before, team A, B, C, and D, everyone knows what they're there to do. So when the response in the humble response of the athletic trainer was, this is my job, that's because it's an EAP and he is assigned that role. It is his job. So the ABCs, in EAP, going out and doing a primary assessment and a secondary assessment, we don't get to secondary unless the primary clears. So ABCs, that's your airway, breathing, circulation, and then starting chest compressions if you find you do not have breathing and no pulse. So that should happen, AHA, American Heart Association, within 10 seconds if possible. And if you replay sort of, well, any injury that happens in the NFL or NBA, athletic trainers are on the court with medical professionals almost instantaneously. And it's for this reason, to be able to do that assessment and figure out what you need to do. Now let's look back. So when you start chest compressions, that's really a temporizing measure, right? We're circulating blood to the brain, to the organs. You're just trying to keep that circulation going. So it's not going to help us long term. It's temporizing, right? We're trying to buy some time, essentially. The AED is the critical piece here. So like I said before, as part of the injury, the fuse trips, and you have to go out to the fuse box. Well, the fuse box is the AED. So when you put that on the athlete patient and you begin to analyze the rhythm, and everybody's walked through one of those, so I don't need to go through it. But when we do that, this is our opportunity to flip the fuse back on, because that heart is not working. And we need to give the body blood. Well, that's not working. So that's again, chest compressions, putting the AED on and giving that opportunity to flip that fuse back on. And that's critical to get that happening ASAP. So that's part of the treatment phase of Commotio Cordis. Anytime that this event occurs, you're going to transport. So that's the final piece. And that's the ambulance, packaging that athlete, making sure that they're stable before you're packaging and sending that athlete to the hospital. And then that team B, as we talked about before, being the emergency department physicians and nurses, receiving that athlete and continuing that care and that communication that's so critical there. And then after that transport in the hospital, brain health is the main concern, to assess any damage that has occurred and the recovery of that athlete patient. Now switching to common injuries, acute and chronic injuries in that case. So I'll cover 4 tonight for the sake of time. And you'll see that they're very similar, but I'll give you sort of the crash course in these 4. So ligament sprains and muscle strains. If you're not in the field, you may see these as rather foreign, but there's really a simple piece here. So ligament sprains or ligaments hold the bones together and provide stability to the joint. Muscles are that mechanical driving force that move the joint. So both of these sprains and strains result of too much too quick or overtraining and improper equipment. I remember when I worked for a prior institution, they had a step contest, and I thought, you know what, I'm going to win this thing. And I had a treadmill desk and I went for it. And I walked probably 15 miles a day in Birkenstocks from a home office, mind you, but no one was there to tell me how bad of an idea this was. And so along with winning that contest, I won a set of shin splints to go with that. Also in this risk factor category is poor flexibility. So if your flexibility is poor and you're just thinking of, hey, I'm going to jump off the couch and go join that church basketball league, bad idea. Ramp up to that, right? Maybe go shoot hoops at the Y, at open gym, stretch a little bit, sort of warm up to that idea, ramp up to playing that pickup game. So the number 1 population that's at risk here is the weekend warrior. And so how does this look when we see it? Localized pain and swelling, weakness, and limited range of motion. And the weakness is secondary to that pain and swelling. Really, the pain is coming from the swelling. So that it's all connected. And then limited range of motion, because we just don't want to use it when it's painful. And treatment for these, very similar, if not exact, and that's RICE, so rest, ice, compression, and elevation. And the critical piece that most people don't follow and they end up getting a rupture is activity modification. So you can't continue to do what caused this. You have to correct it first and then ease back in. And then the general rule of thumb is near full or full range of motion before you begin strengthening. So in the muscle strain category, strengthening is definitely critical. We can't strengthen ligaments. They're fibrous tissues that, again, connect joints. So when thinking about range of motion, you want to get near full before you begin to strengthen. The other pairing that makes a lot of sense when looking at common injuries is tendonitis and bursitis. So if you think of a tendon is a fibrous tissue at the end of a muscle that connects it to the bone. It's really strong. And I consider it like, if I'm going to give a food analogy, a piece of celery. So a tendon is like a piece of celery. It's pretty strong, right? It's hard to chew through, and you're just like, hey, this is pretty, like I can get a really strong dip with this thing. So in that case, it rubs over a bone because it's connecting to a bone, and usually a bony prominence right there where it's connecting. The bursitis the bursa plays a critical role because it sits right underneath that tendon as it runs back and forth over that bone when the muscle contracts. Itis is inflammation, right? So too much, too quick. The repetition piece also enters in here. And that muscle that tendon will push down on that bursa, and that repetitive nature go back and forth, back and forth. And that soft fluid-filled sac now becomes hard. Now it becomes filled with more fluid, stretched out and more like a marble. So when that tendon runs over that bony prominence of where it's inserting, it pops that bursa right out underneath it, and it's no longer doing its role. That makes the tendon more sore. So it's just once we get into that cycle, it's something has to change, or you'll eventually saw off your tendon, meaning that bony prominence will just start tearing it. Like when you bend a piece of celery and it sprigs back, that's what's occurring as it's dragging over that bony prominence. So these can also happen from a blow to a certain area or a fall. So a bursitis that's on the end of the olecranon here, you see this huge bubble. That's usually from someone who has fallen on that bursa, the olecranon bursa, and it's just filled with fluid and blood. Poor flexibility also can contribute here. If a muscle is tight, you can just imagine the tension that puts on the tendon and the bursa, the underlying bursa. So that makes a lot of sense to us. So weekend warriors here, as well as that masters athlete. Another at-risk population. So a lot of you might be that masters athlete and you're thinking about, hey, I'm still active, I'm healthy. Flexibility is your friend. So flexibility routines, making sure you maintain your strength, but flexibility is critical. Similar recognition here, localized pain and swelling, but the two main differences here are squeaky joints and popping with pain. And I described that a little bit. The squeakiness comes from that tendon sort of just getting that swelling in it and causing sort of the squeaky door syndrome. You can feel it. You can't usually hear it. You can feel it. And then the pain and the popping, that's that tendon pressing down on that hardened bursa and it just scooting out of the way with range of motion. Same sort of treatment here with rice, but the focus is on stretching. The final few minutes of the talk will focus on post-concussion symptoms. And I think it's critical to share with this group as well, healthcare providers and future healthcare providers, because staying at pace with developments in the practice of nursing or practice of medicine, the practice of sports medicine or athletic training, it takes consistent lifelong learning. Something like this, I studied concussion and biomarkers about 10 years ago now, and was sold into the post-concussion syndrome. And recently this has changed to post-concussion symptoms because of the negative connotation of the word syndrome. So again, just highlighting that we have to stay lifelong learners in our fields to be able to understand the advances in our practices. So the definition of a concussion is there, but for sport-related concussion, it's really an MTBI, a mild traumatic brain injury. And symptoms typically resolved in 7 to 10 days. It's not something that is long-term, but in the case of post-concussion symptoms or PCS, these are long-term effects, and it happens in 10 to 30% of the population. 40 to 60% of these folks have symptoms longer than 6 months. So it's something that they're struggling with that's now impacting their quality of life. You can already inkle that this is going to hint towards a team-based approach. There are risk factors both pre and post injury for who's going to develop post-concussion symptoms. And I think some of these might be of interest to you because you have children, or you might have nieces and nephews or grandchildren who play sports. History of concussion is critical. So when your children, grandchildren, nieces and nephews have concussions, you should be keeping track. The more concussions you have, the more you should be evaluating your participation in sport or that sport. And the more you should be evaluating the recovery period, because the more you rack up as far as number of concussions, the longer it takes you to recover from those concussions. Gender also plays in here too. So I've got female soccer here right above me. women have more symptoms, report more symptoms, and take longer to recover. So combine that with the history of concussion, and you've got a recipe in the making for post-concussion symptoms. If the athlete has migraines or headaches prior to receiving a concussion, it's likely it's another risk factor for developing post-concussion symptoms. And then learning mood or anxiety disorders, if any of those exist in the athlete prior to a concussion, it can exponentiate those in a negative way. Post-injury, the severity of concussion plays in. How severe it is obviously correlates to their propensity to develop those unresolved symptoms at 7 to 10 days. And then stressors and perception of support. So I want to shine a light on this specifically because stressors are a perception, life stressors that you perceive in your environment, as well as perception of support. So as the athlete is recovering post-injury, if these aren't perceived, if stress is high and that support is low, this can contribute to development of symptoms. So I wanted you to look at this slide and look at the blue box and think about some of these things. So you have a patient who's reporting they have these things. So fatigue, double vision, they're nauseous, headache, irritable, sleep disturbance, poor memory. And then I want you to think about one healthcare provider that can address all of those and challenge you to do that. It's a good exercise for students to parse apart, what team member has the skill and what kind of a team do we need to put together to address the post-concussion symptom athlete. So here's more of a table approach to this, but I want to focus in on the left or the right margin, that healthcare team, because you've seen these symptoms in the prior visual. This healthcare team on the right side, the athletic trainer, and it's alphabetical. The athletic trainer, the cognitive psychologist, the physician, the physical therapist, the sports psychologist. Now, the reason you don't see nursing here or a nurse or a type of a nurse is usually that happens in the emergency department, that feature or that piece, unless they're in for sleep therapy or something like that. So on this team in particular, handling these things on the left side, this is the proposed healthcare team. And this comes out of a textbook chapter on post-concussion symptoms. So concluding the talk tonight, just thinking about the things that we covered and thinking about team-based care and the benefits of teaming, anchoring back to the quintuple aim for healthcare and thinking about cost of care, thinking about population health, thinking about that patient experience, and then adding on that care provider's experience, which was so critical to think about them because they have a direct impact on that patient care and the quality of the care that patient receives. And then thinking about health equity. And are all patients able to access affordable care at a high level quality, affordable care? Does that exist? So I challenge you to think about that and lead your students through that paradigm to understand, what are the limitations to the current healthcare system in your region. And I know Intermountain Health does a great job trying to navigate that. So that would be a good case study. Uncommon injuries, emergency action plan, we went over that, and it's the recipe for success for those teams and coordinating that effort. It's like conducting an orchestra, really. It's very, people have to come in at certain points in time and to make it all go well. So it is indeed a work of art that was witnessed on the sidelines of that NFL field, and seconds count in that scenario. And then finally, post-concussion, it does take a highly specialized team with a coordinated effort to fully recover athletes when they get into that scenario, post-concussion symptoms. And communication becomes critical. In highly specialized networks, it's often at a distance that folks are receiving this care. So in a psychologist's office that's far departed from the physician who's leading the care or the nurse practitioner who's leading the care, it can get really disconnected really fast. And that really places the onus on those care providers to keep that communication network tight to ensure that patient care is high, patient care level, and that experience. And that is it.
No, thank you so much, Dr. Utley. As a non-clinician and a proud weekend warrior, I also took some notes on things I should caution myself against when I choose to be really active. So with that, we will open it up to any questions. The webinar is scheduled to conclude at 7 p.m. Mountain Time, and so we have a couple minutes here. If there are any questions, feel free to type those in the chat. We'll hold for questions. And if not, we'll just conclude early.
I want to add to that with Josh's, Dr. Utley, same kind of thing. The weekend warrior is probably my issue, and that's probably how I ruptured my Achilles back then. It was like, I can do this. I did this all in high school and all that time, and all of a sudden it just snapped. And the stretching, I know stretching is a huge component. Is there any data as far as the best time to stretch? Like mornings before going to work, doing like a quick run, stretching, or at night when you get home and do your workout? Or is it more just make sure you're kind of warmed up and a little loose?
So there is data on that, Taylor, and it's as far as conclusive findings, no, there's an individual difference there of your tightness of your musculature, right, and how much you need as an individual. But I think the critique came when we had athletic teams out on the field like an hour before the event stretching, and that was really where the critique came as far as the timing of when that stretching was taking place and when they actually took the field. Stretching is never a bad thing. But the benefits of stretching and is it going to minimize the injury? I think that's the key piece that you're asking about. And the research is not conclusive in that area. There's a lot of individual difference and sport type and actions like basketball's jumping, some sports like hockey are not jumping, they're lateral side to side. So there are a lot of factors that go into that.
Thank you.
Dr. Utley, I have a question for you. So this is Janet Houston. I'm the Dean of Nursing, but I started my nursing career as a pediatric nurse practitioner. And so often I would be asked to all my children's sports teams and all the different things that we did to be that person to help. And for all of us that have kids in sports or had kids or will have grandkids again someday, what are your recommendations for a group of nurses to really understand what they should do in those situations? What kind of continuing ed, what kind of supplies, what would your recommendations be?
Sure. General care is blood, so Band-Aids, 2x2s or 3x3 gauze pads. I mean, that would be something that I would have on hand. So as far as a kit, cooler of ice and bags. Sometimes it's just ice for youth sport that's going to heal most things. European sports, you see the spray, the magic spray that comes on the field. Well, it seems like for youth sport, that's ice, and trying to calm their pain or trying to keep that swelling down so it doesn't look like a grapefruit on the side of your ankle the next day, which freaks everybody out. But I think too, a communication with that sports league as a mom and saying, hey, you need an athletic trainer. Like, this is not something that you're just going to ask a nurse on the sideline to engage with. It's like asking me to do your role as a pediatric nurse, right? It's difficult. The skill overlap is not there. It might be 10%. Like, we both can put on a Band-Aid. We both can. So I think I'm saying that to be fully transparent, that I think moms and dads and uncles and aunts need to demand the care that the children deserve, and that is someone who's skilled in that area to be on that sideline, especially if it's contact sports. You saw in the slides that I presented, there was a factor on flag football versus helmet football. If there's ever in the state of Texas, and it happens often, a youth sport field that doesn't have an athletic trainer that's playing contact football, I mean, parents should all walk away, because that is not safe in any way, shape, or form to conduct play or practice. And we know that it's not happening at practice. So I think it's really going to take a parent movement, a grandma movement, a grandpa, again, aunts and uncles, to really step up and say, hey, you need this person, because we're a physician or a nurse and we can't provide this. Like, it's a specific skill set. It's like asking a GP to do a concussion evaluation on the sideline. And usually those GPs are like, Jordan, can you come over and do it? And I'll be here in case you need me. So we all play that partnering, that teaming role. And when we're teaming together, that's when the best care happens. Sorry, that wasn't a great answer.
No, it was a great answer. And it's how I have felt over the many, many years of high school sports for my kids. So yes.
We do not have any questions in the chat. We have several comments just thanking for the information, really appreciative of your time. And so if there's no other questions, on behalf of Joyce University, Dr. Utley, I'd really like to thank you for taking the time and sharing the information with us today. We've recorded this presentation and we'll share it with all of our faculty and students and make it available to them as well. If you have any closing remarks, otherwise we will dismiss people for the evening.
No, I just really appreciate it. And I appreciate the efforts of Joyce to get this information across healthcare practitioners and to bring together in an educational event this group to really focus on teaming and how we can provide better care and shape the future of our current students aspiring to be in the roles that we're in. So I appreciate that.
Excellent. Well, thank you, Dr. Utley, and everyone. Have a wonderful evening. We appreciate it.
Bye.